Bismillahirrahmanirrahim. In this video, we are going to study about acne rosacea and acne vulgaris. The disclaimer is that it is not any medical advice. So now you have to decide which of the following is acne vulgaris and acne rosacea. This is acne rosacea and this is acne vulgaris. How to differentiate between the two? So, in acne rosacea, the sebum secretion is normal and the comedones are absent. What is acne rosacea? Acne rosacea is a chronic inflammatory condition that affects the central face and consists of flushing, erythema, papules, pustules, and telangiectasia. Whereas in acne vulgaris, which is also a chronic inflammatory condition, but this is a chronic inflammatory condition of the pilosebaceous units. What are the pilosebaceous units? In which the gland is basically connected to the duct of a hair follicle. So it basically starts after puberty. It is extremely common and there are reports of it affecting over 90% of the adolescents. It is usually most severe in the late teenage years but can persist into the 30s and 40s, particularly in females. It affects both the face and the trunk, and the greasiness of the skin is obvious, which is called seborrhea. And the hallmark is a comedone. It can be an open comedone, which is basically a black head, which is basically dilated keratin-filled follicles, which appear as black papules due to the keratin debris. And there are sometimes closed comedones, which are white heads. These closed comedones usually have no vesicular follicular opening and are caused by accumulation of sebum and keratin deeper in the pilosebaceous units. And apart from that, there are inflammatory nodules, papules, and cysts and may arise from the comedones. Scarring may follow deep-seated or superficial acne and may be keloidal. What are the causes of acne vulgaris? It is caused by increased sebum production, colonization of pilosebaceous ducts by Propionibacterium acnes. Androgens and progesterone increase sebum production rate while estrogens reduce it. A positive family history, genetic factors although genes are not known, environmental factors or dietary habits, stress and psychological factors. In this picture, you can see a pilosebaceous unit. This is basically a sebaceous gland which is basically connected to the duct of a hair follicle. The opening to the pilosebaceous duct is blocked because of the activity of this Propionibacterium and because of increased sebum production. Sometimes this increased sebum production leads to the rupture of the obstructed sebaceous gland with the release of contents into the dermis. So the main primary cause is increased sebum secretion rate and the accumulation of Propionibacterium acnes, which in turn causes inflammation and hypercornification and ultimately the occlusion of the pilosebaceous duct, which leads to the worsening of the sebum production, increased sebum rate and inflammation. Here are the factors that may cause acne, which include diet and cosmetics, hormones, stress, smoking, and environmental and bacterial causes. What are the causes of acne rosacea? The causes of acne rosacea are mostly unknown, but it has been seen that there is some contribution of the Demodex mite or cutaneous vasomotor instability can also be a cause of acne rosacea. There are multiple variants of acne vulgaris, but we are going to discuss only 4. The first one is acne conglobata. It is characterized by comedones, nodules, abscesses, sinuses, and cysts. superimposed by marked scarring. It is rare, usually affecting adult males, and most commonly occurs on the trunk and the upper limbs. It may be associated with hidradenitis suppurativa, a chronic inflammatory disorder of the apocrine glands, predominantly affecting the axillae and the groins, the scalp folliculitis, and pilodinal sinus. These two pictures show acne conglobata. Now let's talk about acne fulminans. This is the picture of acne fulminans. Acne fulminans is a rare but severe presentation of acne. It is usually associated with fever, arthralgias, and systemic inflammation with raised neutrophil count and plasma viscosity. It is usually found on the trunk in adolescent males. Costochondritis can occur as a complication. Let's talk about acne excoriae. It describes self-inflicted excoriations due to compulsive picking of pre-existing or imagined acne lesions. It usually affects teenage girls and underlying psychological problems are common. This is the picture of acne excoriae, showing excoriation of the skin. Let's talk about secondary acne. Secondary acne can be caused by multiple causes. It can be caused by greasy cosmetics or occupational exposure to oils, tars, or chlorinated aromatic hydrocarbons. Predominantly pustular acne can occur in patients using systemic or topical corticosteroids, oral contraceptives, anticonvulsants, lithium, or anti-neoplastic drugs such as the epidermal growth factor receptor inhibitor cetuximab. Most patients with acne do not have any underlying endocrine disorder. However, acne is a common feature of PCOS, which is polycystic ovary syndrome, which should be suspected if acne is moderate to severe and associated with hirsutism and menstrual irregularities. Virilization should also raise suspicion of an androgen secreting tumor. So, the next thing that we'll talk about is the investigations. Investigations are not required in typical acne vulgaris, but investigations may be required in case of PCOS or virilization, in case of any underlying endocrine disease, or in case of secondary acne, which is definitely caused by the causes that I've just mentioned. Let's talk about the clinical features of acne rosacea. Acne rosacea most commonly affects fair-skinned, middle-aged females and can be exacerbated by heat, sunlight, and alcohol. The convexities of the nose, forehead, cheeks, and chin are typically involved. The condition is heterogeneous, and in some, intermittent flushing followed by fixed erythema and telangiectasia predominate. In others, papules and pustules are prominent. Sebaceous gland hyperplasia and soft tissue overgrowth of the nose, which is called as rhinophyma, can occur, particularly in males. Conjunctivitis and blepharitis may occur. Facial lymphedema can be an added complication. Again, in this case, no investigations are required and the diagnosis is obvious clinically. What are the differentials of acne rosacea? You have to exclude acne vulgaris, SLE, photosensitivity disorders, and seborrheic dermatitis before making the diagnosis of acne rosacea. What is the management of acne vulgaris? In case of mild to moderate cases, you can start with the topical therapy. Especially in case of mild disease, you can use topical benzoyl peroxide, and topical retinoids. Treatment should initially be applied at low concentrations for short duration and increased as tolerated. Azelaic acid may also be useful for mild acne. Patients with mild inflammatory acne should respond to topical antibiotics such as erythromycin or clindamycin, which can be used in combination with other treatments. Now let's talk about moderate inflammatory acne. In moderate inflammatory acne, a systemic tetracycline such as oxytetracycline or limicycline or doxycycline should be used at adequate dose for 3 to 6 months in the first instance. If the case fails to respond, then alternatives include erythromycin or trimethoprim. Estrogen-containing oral contraceptives or a combined estrogen anti-androgen contraceptive may provide additional benefit in women. Patients should be referred for a consideration of isotretinoin, which is basically 13-cis-retinoic acid, if there is a failure to respond adequately to 6 months of therapy with these combined systemic and topical approaches. Now let's talk about the treatment of moderate to severe disease. Isotretinoin has revolutionized the treatment of moderate to severe acne that has not responded adequately to other therapies. It has a multifactorial mechanism of action with a reduction in sebum secretion by over 90%, follicular hypercornification, and P. acnes colonization. A typical course lasts for 4 months in case of isotretinoin. Sebum excretion usually returns to baseline over the space of a year after treatment is stopped, although clinical benefit is usually longer lasting. Many patients will not require further treatment, although a second or third course of isotretinoin may be required. A low dose continuous or intermittent dose regimen may be considered for a longer duration in patients who relapse after a higher dose regimen. Combination with systemic steroid may be required in the short term for severe acne in order to minimize the risk of disease flare early in the treatment course. Thorough screening and monitoring are required given the side effect profile of isotretinoin. So when you're giving isotretinoin, you have to do investigations of your liver function tests, of your renal function tests, and the other baselines. They should also be investigated. What are the other treatments and physical measures? Intralesional injection of triamcinolone acetonide may be required for inflamed acne nodules or cysts, which can also be incised or drained or excised under local anesthetic. Scarring may be prevented by local adequate treatment of active acne. Keloid scars may respond to intralesional steroid or silicone dressing. And this is steroid injection is for keloid scars. Carbon dioxide laser, microdermabrasion, chemical peeling, or localized excision can also be considered for scarring. UVB phototherapy and PDT can occasionally be used in patients with inflammatory acne who are unable to use conventional therapy such as isotretinoin. There is no convincing evidence to support a causal association between diet and acne. The psychological impact of acne must not be underestimated and should be considered in management decisions. Let's talk about the management of acne rosacea. In mild disease, you can use topical antimicrobials such as metronidazole, azelaic acid, tetracyclines, or erythromycin for 3 to 6 months. And relapse may require intermittent or chronic antibiotic use. Erythema and telangiectasia do not respond well to antibiotics, but laser therapy can be effective in case of complications. Like I said, relapse. Relapse mein to you have to use intermittent or chronic antibiotics. But in case of erythema and telangiectasia, you have to use a laser therapy. Systemic isotretinoin may be helpful in severe resistant disease, and rhinophyma may need laser therapy or surgery. So this is all for today. I hope you understood. Thanks for watching my video.